What I'll be talking to you about today is children's cancer. I want you to understand what it's all about and what CRUK research has done to contribute to it. Now, when I use the CRUK, because some of it's historical, it refers to the ICRF, CRC, pre-merger as well as post-merger. Okay, so why bother having a Children's Cancer Awareness Month? I mean, let's face it, it's really rare. Only 1 in 600 children will get any sort of malignancy by the time they're 15 years old. 1 in 3 of us here will get cancer. The children's survival now, if you're newly diagnosed with cancer, 75% of those children are cured. And the results are getting better by 10% per decade. So the mathematically minded amongst you will say in 30 years' time, children's cancer will be positively good for you. Now, actually, there are reasons why, even though it's only 2% of the total cancer burden, I think it's desperately important. The first is that children's cancer is the leading cause of death in childhood. 18% of all deaths in childhood are due to malignant disease. That's more than accidents, that's more than congenital malformations, that's more than heart defects, respiratory disease, everything. It's cancer that is the big one. Now, a diagnosis of cancer is a tragedy at any age group. But if you're an 86-year-old gentleman and you've got a low-grade cancer of your prostate, and you've got heart disease, and you've got lung disease, it's still a big deal, but it might not be your biggest risk. And if you do succumb to it, of course that's a tragedy, but it's 3, 4, 5 life years lost. If you're a 3-year-old with neuroblastoma, it's your only risk of dying. And if you die, it's 80 years that you've lost. Now, it's not just those statistics that make it important. It's the fact that every single diagnosis is a personal tragedy. All parents expect to outlive their children, and the repercussions for nuclear families, extended families and beyond of a diagnosis of a child with cancer are enormous. For example, 70% of the couples that come into us having a child diagnosed with cancer end up having marriage splits. Simply the pressure is far too much to bear. It's difficult. Okay, well, it's rare and it's difficult, so we ought to treat it, but why don't we just use adult protocols to treat children? Well, firstly, the diseases are completely different. The big diseases that happen in adults, stomach, colon, breast, lung, are vanishingly rare in children. If you look at the diseases which sound the same, like brain tumours, they're completely biologically different in children. And the treatments you can use are different. In a fully formed adult, you can do a particular sort of treatment. If you've got a one-day-old baby who's got to grow to a full adult size, you can't interfere with that growth and development, or else you're really not doing that child any favours. So they require different treatments. All right, well, why don't we just stop childhood cancer happening then? Well, we can't, because we don't understand why it happens. Unlike in adult oncology, where stopping people smoking, giving them sensible sunshine advice, making sure that they don't drink too much, those are all good public health measures. We have absolutely no clue whatsoever why childhood cancer occurs. We know quite a lot about what's gone wrong in the clockwork of the individual cancer cell, but we've got no clue as to what stimulus created that problem. We've looked. We did a 5-year study where every single child who was diagnosed with cancer in England or Scotland was matched with parental consent with another child as geographically close as possible. Same sex, same age. We went into the homes, we did a 1.5-hour lifestyle questionnaire, we looked for radon, power lines, mobile phones, everything. Not a single clue at the end of 5 years. We simply don't know what causes it, so we can't stop it. Okay, let's start looking a little bit about the history of childhood cancer. 75% sounds a fantastic figure, and it is. When you consider that in the 1930s, everybody who was diagnosed with childhood cancer died of their disease. As a clinical example, I'm going to be using, medulloblastoma, which is a tumour I'm particularly interested in. It's a primitive tumour that happens here at the back of your brain in the organ of balance, the cerebellum. And it was a really brilliant neurosurgeon in the States called Harvey Cushing who really described this tumour and in the 1920s started operating on it and removing it. And he managed to extend the survival of children diagnosed with medulloblastoma from a number of weeks or short number of months to about 17 months by doing that. Along with a neuropathologist called Bailey, they worked out that it was a primitive tumour. They'd heard of radiotherapy being given in the UK and started doing that for children with medulloblastoma and gave them an extra few months. But still, they all died. Slowly, through the 1960s, it became established to cure it, what you need is a good removal of the tumour and radiotherapy to the whole brain and the whole spine. Everywhere that the spinal fluid goes, you've got to do the radiotherapy or else it will come back. And the doses were pushed and pushed and pushed until when I became a consultant in 1993, standard risk medulloblastoma had a durable survival rate of around 60%. So that's fine, okay? We're pushing the treatment harder and harder, we're getting better and better results, so let's keep on pushing the treatment harder and harder and get even better results. The difficulty was that we started realizing just how badly the treatment was affecting the survivors. They were getting terrible late effects. Now, talking about late effects when you've been cured of a fatal disease seems, I don't know, a bit ungrateful. I mean, what do you want, perfection? But actually, it's not even close to perfection. If you've had your head and spine irradiated at a young age, you will be growth hormone deficient, okay? You get growth hormone. You will lose 10 centimeters of final adult height, okay? You'll be short. You will have a risk of second malignancy, all right? It's only 3%. But most importantly, you will have profound neuropsychological problems. Your IQ will drop, and it will drop year on year. And more importantly, the way you use your IQ will drop. Now, all of us have had the experience of being at a party and talking to somebody intently and being really engrossed in the conversation, and somebody somewhere in the room says your name, and you turn around and look at them. Your brain has filtered out the white noise, it's directed your attention to where it should be, something else comes up and it directs it back. Children who've had craniospinal radiotherapy just can't do that. They just can't concentrate. And in the modern world of a school or a workplace, you need to be able to do that. So if you can't concentrate, you've got a low IQ, you might have balance problems from the tumour, you might have a weak right side, you might have visual impairment. These children had profound problems. When we looked at them 15 years on, it's a paper published by Kilty from Manchester, we found that the vast majority of children who'd had radiotherapy under the age of 3 years were not living an independent adult life. They were living in an institution, and that's what no parent wants for their child. So we couldn't push it any harder. So the treatment wasn't good enough to cure 40%. They were still dying. And 60% all had the late effects. Now, what if medulloblastoma wasn't one disease? What if there was a lower risk group who needed less treatment? We could damage them less. And what if we could identify the 40% that were going to die up front and do something different, stronger, new? That'd be a good thing to do, wouldn't it? Which brings us onto the whole idea of risk. When we look at risk, we normally look at it just in terms of the threat. So a motorcycle is a dangerous way to get to work. Horse riding is a dangerous sport. I don't think that's the whole picture. And in order to help me with that, Liz, Laura, and Nina are I've set them up to help me in this little skit. And their risk is getting wet. I have a 20 ml syringe full of water, and I'm going to spray it at them, okay? And I'm not a heartless man, so I've made sure that they all have a degree of protection against this 20 mils of water, all right? Liz has a barber, Laura has a light cotton jacket, and Nina has a tissue. Okay? I'm not really going to do it because it would get messy. Laura, if I sprayed you now, what would happen?
Definitely get wet.
Definitely get wet. Laura?
I'd be fine.
You'd be fine.
I'd be fine.
You'd be fine. Okay? One threat, two different responses. Okay? Here's another threat.
Definitely get wet. I think I would get wet.
No, I think I'm fine.
So you're sitting pretty at the moment. Again, But what if I brought a fire hose in? What would happen there?
I think I would get wet.
You'd all get wet. Okay, thank you so much for being props and willing participants. Okay, now the point of that, apart from giving you a giggle, was the fact that we've got one threat. And yet it constitutes a very different risk depending on the sort of protection that we're given. So if you take that back to medulloblastoma, Cushing didn't need to talk about risk groups. All his patients died. Yeah? If we invent a small white tablet that cures everybody with medulloblastoma, all the subgroups will still exist, but actually they wouldn't be relevant in terms of risk. It's because we've got imperfect treatment, which has got big consequences, that we need to divide people into risk groups. And that's what I do every day at work, trying to find out what the threat is from the disease and try and marry the treatment, which is my version of the Barber raincoat, to the appropriate extent. Okay? Now, so if I can find that there's a relatively non-aggressive form of medulloblastoma, then I can give people less treatment. If I find it's pretty aggressive, I'll give them the Barber. If we find it's the fire hose, then I have to sit down and have a really heart-rending conversation with the family and say that there really isn't any point putting their child through aggressive chemotherapy and radiotherapy because it's painful and difficult and it's not going to cure them anyway. And we either need to do something completely new or just make sure we look after their symptoms. Possibly the worst conversation I have to have in my practice. All right, well, how do we define risk? Well, what you need is a population of children treated in the same way, and then you look back and you see what factors were related to survival. And in the 1970s, CRUK funded the United Kingdom Children's Study Group, where doctors started treating children with medulloblastoma in an identical way and sharing their results across the world. Now, there were some easy picks there. If you had a big tumour left, you were high risk. If the tumour had spread around your brain and spine, you were high risk. But one of the really main differentials, discriminators of risk, was involving the neuropathologists. Now, until the 1970s, there wasn't an accepted worldwide classification for neuropathology, so it was pretty difficult to get a sensible answer. But once that started, they started recognizing that different sort of patterns of medulloblastoma, and if we related those back to the survival, we could see good ones and bad ones. We could almost tell by what the cells looked like how they were going to behave. Now, here's an analogy that might be helpful in that regard. Imagine you stand on Victoria Station in the morning at 8:30, and you're trying to work out what the people coming off the train are going to do all day. So you've got a bloke with a spirit level and a bag of tools. It's probably going to be a builder, okay? You've got somebody who's impeccably dressed, very suave, cultured, relaxed. He's definitely not going to be a doctor, okay? And you'll differentiate people into some groups, but there'll be a mass of people who are just vaguely smartly dressed, holding a bag of some sort, going to work. And you're stuck. And that's how he was stuck, with classical histological and normal everyday staging of tumours. The real key would be, what if you could grab their diaries and look in their diaries and say, what is the information that you are being told to do today? And that's where molecular biology has been such a fantastic plus. Now, CRUK deserves an enormous amount of credit. They spotted very early on that the ability to look at the DNA of a cell and look at its behavior was going to be key to understanding cancer. They put huge amounts of money into getting the best scientists in the best labs to work on individual cells. What makes this cell live? What makes it die? What makes it grow? Then moving up to really simple organisms like worms and frogs. How does that cell interact with other cells? How does it get a blood supply? How does it not interfere with other things? These really basic bits of science. And they got quite a lot of flack for it. People were saying, hold it, people have donated money to cure cancer. This is all very nice. What's it doing? Well, boy, is it bearing fruit now. Because in the medulloblastoma field, we've just completed a study a couple of years ago, standard risk medulloblastoma, 82% survival. Now that's good. But within that group, all the children get radiotherapy, all the children get a year of chemotherapy, they've all got feeding tubes, half of them are in a wheelchair. It's pretty tough stuff. By collecting all their tissue and looking back and looking at their molecular pathology, we found a group that have got an over 90% chance of survival with one molecular pathology pattern and a much worse survival with another. And it's very powerful. So if you've got beta-catenin accumulation in your nucleus, the good one, then even if the disease has spread, even if it's left, even if it looks really ugly down the microscope, you're going to do really well. And if you've got too many copies of the MYC genes that force the cells to grow, even if it hasn't spread, even if it's all been removed, and even if it looks lovely down a microscope, you're going to do badly. And so what we're doing in the next study, for the first time ever, and this is a study funded by CRUK and the Brain Tumour Research Trust, we're stratifying up front at the time of your initial surgery. We're using that to put you into different groups. And so the good ones are going to get much less chemo, much more tolerable, and the bad ones who are going to get be randomized to a study which tries to improve survival by increasing the aggressiveness of treatment. A proper risk-stratified study, and that's fantastic. So far we've looked at what CRUK has done about getting teams of doctors together, about teams of scientists together, but it's all at the kind of understanding the threat so you can do normal treatment. How about trying to do better treatment? And that's the great hope of molecular biology. Because the way that we normally treat cancer at the moment is that we try and kill cancer cells. We say that the only good cancer cell is a dead cancer cell, and we give toxins such as radiotherapy, such as chemotherapy, which affect everything. And we assume that the normal cells have got repair mechanisms and can repair themselves, and the abnormal cancer cells haven't got those repair mechanisms and will die. It's pretty crude. But actually having a few cancer cells in you isn't a problem. What's a problem is those cancer cells growing, getting a blood supply, growing further, spreading and invading. That's what kills you. Now, if we could understand those processes, growth, the acquisition of a blood supply, spreading and invasion, and block those, it really doesn't matter if a handful of cancer cells are hanging around. Okay? Now, those drugs, it's not pie in the sky. Those drugs have been developed. They're now in clinical trials. We're just beginning to get a handle on how to use them in such a way that you can block a cancer cell growing but not stop your blood cells growing. You can stop a cancer cell getting a new blood supply, but you're not stopping a growing limb, for example. We're right at the beginning, but it's a fantastic place to be. It's a really exciting place to be in oncology because a whole new raft of possibilities are opening up. And that's due to the research that Cancer UK has funded, amongst other organisations. Okay, I'm going to kind of come on to one extra bit now, where Cancer Research UK has really helped. And it's helped in a way that it's not interested in and hasn't funded. And that's improving the quality of care. Now, Cancer Research isn't into going around and auditing people. That's not its job. It's a research organisation. But if you think of it, if you're trying to get the best outcome from a child with medulloblastoma, if an excellent surgeon can remove it all and a good surgeon can remove most of it but leave some behind, well, the excellent surgeon is going to be of benefit. We know, for example, that if you miss a tiny bit of the radiotherapy, a tiny bit of the CSF area, you're going to relapse there. And radiotherapy misses are a big cause of relapses in medulloblastoma. And we know if you're pushing chemo, if you don't have your chemotherapy run by somebody like me with really bad OCD actually, and a team behind it with the same sort of character spec, then actually it's not going to work. The normal audits are post hoc, you know? You come in every 6 months, you see what you've done. It's useful, but it doesn't help those individual children at all. But the studies that Cancer Research insists we do are central pathological and radiological review up front. Somebody's checking you've got the diagnosis right. Central review of residual disease, a team of other surgeons saying, Can we get this? Are we sure? Central review of radiotherapy planning before we give the radiotherapy, and course-by-course assessment of chemotherapy, because that's the data we have to submit back to the clinical research units. So that's not what cancer research set out to do. It's not its aim, but in running a well-conducted study, it's forced everybody to step up to the plate, and it's forced the improvement of quality of cancer care. So I think it's a fantastic organisation. You've gone from basic science to translational science to funding research to funding groups of people to talk about the research. You ought to be very proud to work here, and I'm very honoured to talk to you. Thank you very much.